Yeah, he's here as well. Yeah.
That's great. Yeah. All right. You can hear me. You can see my screen. All good?
Yeah.
Okay.
Yeah.
Perfect. So, good afternoon, everyone, or good evening, if you're in the UK. First of all, thank you for staying on to keep attending this workshop. We have a very long day, but hopefully fruitful one. The panel is on responsible AI challenges and opportunities. I'm Professor Dhaval Thakker. I'm a director of research in School of Computer Science at the University of Hull, and I'll be chairing this particular panel. So we have got to assemble a great panel together. We have on the panel, when I say a name, if you can just wave your hand, Will Jones, who is a lecturer and director of research for Data Science, AI, and Modeling Center, short for DAIM in University of Hull. Again, from DAIM and University of Hull, we have Kevin Pimbblet, he's the director of DAIM. We have Raghu, Dharmaraju, CEO of ARTPARK, fellow of Reimagining India's Health System, a Lancet Citizens Commission. We have Raghu, yeah. Milind Pande, medical director and consultant, ophthalmic surgeon, vision surgery and research center. He's also founder and CEO of CustomLensAi, which is what he covered in his talk this afternoon. We have Srinivasan Parthasarathy, professor of computer science and engineering at the Ohio State University. We have Koorosh Aslansefat, who is a lecturer in computer science at University of Hull. So the format of panel is I had requested all the panel members to prepare 3-minute talk, whether that's through the slide or if they would like to just talk, to try to talk about this question, which is responsible AI, responsible to whom, challenging the one-size-fits-all approach in global health. And I will ask the panel members to go one by one and talk on this question or this topic. We'll follow that up by some questions, initial questions I would have from the presentations they would do, but general theme of the workshop. And we'll have a discussion on that. But I would invite the participants in the workshop also to send their questions while we are discussing. If you have something to add to that or a question to ask based on the discussions we are having, please feel free to do so. I will try to weave your question in if I can in the discussions, or I will definitely try to come at the end, depending upon the time. But that's the format we'll go with. So I will stop my screen now, and I will request, first of all, if Will, you are okay to go first?
I can try. So I put some slides together as the day has been unfolding, but they're a bit erratic, and there's no clear narrative to them. But we can see what you think about them, I guess.
That's okay.
Sorry, 1 second. Can you see some slides? Oh, can you see slides?
No, not yet.
No.
You see the call screen?
I think that's your screen, isn't it?
I'm not that familiar with Zoom, so bear with me. It should be a screen share, so you should be able to see the slides now. I'll just give it 10 seconds.
You have started them in presentation mode?
I have now.
I think your Zoom window is shared instead of the presentation.
Yeah.
Sorry. Try the inter. What about now?
No, not yet.
Oh, I apologize for my incompetence. Is anything sharing?
No, I think when you click on share, one of the option would be entire screen. It will say something like desktop one,
Yeah, I'm pressing that.
and you clicking share button at the bottom.
Yeah. Oh, please grant browser access. Oh, it's requiring access.
Okay. While you sort that out, may I jump to Kevin, if that's okay, for you to start off, and we'll come back to you
Yeah, apologies for that.
next, or maybe later on. Just give me heads up when you're ready. Yeah. Kevin, if it's okay, you can go next.
Yeah, I can go, absolutely. So, Dhaval, you asked me to say a few words about myself as well, so I'm just going to talk on that for just a moment without too much self-promotion, I hope. So my name is Professor Kevin Pimbblet, and I'm the Director of the Centre of Excellence for Data Science, Artificial Intelligence and Modelling, otherwise known as DAIM, at the University of Hull. DAIM is a distinct unit within the Faculty of Science and Engineering. It's also very interdisciplinary. We've assembled a team of about 20 researchers and probably a slightly larger number of PhD students, many of whom are attending here today. And we have expertise right across from the usual suspects of mathematics, computer science, and physics, right the way through to far STEM in biology and so forth, and indeed non-STEM. We've hired AI ethicists, for instance. My own background, I don't know if you can hear it in my accent, is both from the United Kingdom and Australia, which, for those of you who follow cricket, makes the Ashes a very tense situation in our household. And if you want to ask me about that a little bit later on, you're very welcome to. So I've spent most of my career in one of those two countries, and I read my PhD at the University of Durham in the 1990s before emigrating to Australia. And I did quite a number of years at the University of Queensland in Brisbane, followed by some years in Monash in Melbourne. I came back to the UK to do a sabbatical at Oxford University, and at that point, my wife said she wanted to move back to the UK. Thank you very much. So we arrived at the University of Hull, and I've been there since, I'm looking at people, but nobody will remember, 2014, I think it was. So I've probably been there about 11 years now. And in that time, my research has progressed from its origins, which was originally in astrophysics, and I'm not going to make no apology about that. That was my training in the 1990s. But in the early noughties, I was probably one of the first adopters of machine learning and AI back in the day. And we started applying it into problems in physics. And if you have a look at the publications in machine learning and AI, and you can see an almost exponential growth to this day, but we were one of the first to do so. And my research tends to focus around the big questions, such as why are we here? What did the universe do for us anyway? And how do we tell the evolution of it? But more so these days, I'm quite a Swiss Army knife because I've got interests wide-ranging from natural language processing right the way through to autoencoders to denoise imaging, and this has a lot of different applications. So I'll turn now to what Dhaval asked at the beginning. There's a real provocative question there about responsible AI and who is it responsible to anyway? And I think there's multiple correct answers. And in fact, I do wonder if there's even a wrong answer here, which probably makes it even more interesting because at some level, yeah, you've got to be responsible to, let's say, the government, and you've got to keep within the law. Responsible to your peers. So certainly if you undergo peer review, then you're going to be responsible to those people. But that's kind of missing the point, I suppose, because when we talk about the global north and the global south, there are vast disparities across a wide range of different points. And that might mean how rich you are, how disadvantaged you might be. It might be the environment. It might be healthcare. Are you part of an underrepresented group? Now, that might be underrepresented in the West, but it might not be underrepresented in different nations. What about the general public? What about big business? What about the regulators? What about even yourself? Didn't we hear such a fascinating talk a little bit earlier on this afternoon about whether your data has been used to be trained upon? And I think that's absolutely fascinating. There's a lot of really interesting problems contained under the proverbial hood of all of those different categories. So when we talk about responsible AI, I think there's a lot of different things that go into there. And I liked what we did at menti.com right at the start of the meeting. For those of you who are joining from the UK, I don't know whether you were awake then, but we had a really interesting discussion about what responsible AI even means. And words like trust and ethics came up a lot. I was very interested to see the word alignment come up as well, in the sense that can AI, and particularly Gen AI, particularly, I suppose, can that be used for the general good of people? Can it be aligned to human need and human development? So I think there is a lot of different territory that's covered by the question or even the phrase responsible AI. So I hope I've just outlined quite a few of these, and maybe it'll be ideas for colleagues and attendees just to bounce ideas and questions off. Thank you very much, Dhaval.
Thank you for that, Kevin. We'll keep exploring this further. Next, if I can request Milind to go next.
Let me see if I can put my slides up. Okay. You see my screen?
Yes.
Great. So we've spent the whole day talking about responsible AI and the why and the what. We know it's pretty clear why we need to be responsible AI and what responsible AI means. What I'd like to focus on is really the who, when, where, and how of responsible AI, especially within the perspective of responsible AI in healthcare. So who are we responsible to? The question, you could put this in a perspective where you have to look at it both ways. Who is the AI responsible to? Is the AI responsible to patients? Is the AI responsible to doctors who are going to use it to treat patients? Of course, it might well be that the AI interfaces directly with the patient, in which case the doctor doesn't come into play. But those two factors are something which one has to keep in mind in trying to answer this question as to who is the AI responsible to. The second question comes, who will deliver this responsibility? Is it the doctor who's going to use it, the medical professional? Is it going to be the company that develops the AI? Is it going to be the regulatory authorities, which may be government, or will we let the market do whatever it can and cannot do? So these are important aspects to think about in responsible AI as to who's going to do this for when and who will deliver that responsibility. Let's look at when can we deliver this responsibility. Well, we could do this when we design the AI systems right from scratch. More importantly, we could do this, as generally happens with all medical devices, after a clinical evaluation and approval by regulatory authorities that have gone through the system to establish safety and efficacy. And then there is a tradition in healthcare of having post-market surveillance put in place to continually evaluate whatever the device or the software, the AI software is designated as software as a medical device through regulatory authorities. So we think of this as a medical device as it assists various things. So those frameworks need to be thought of and put in place. Where are we going to do this? Well, We could do this at the pre-model stage. We could do this within the model itself and after the model, as we talked about in terms of the evaluation and the regulation. So there are all these opportunities that come in place. The most challenging thing is, how are we going to do this? And this is something which I think things are evolving as all of us come to grips with what AI is delivering today, what it's possibly delivering tomorrow, the hype of what it can. So the whole spectrum of AI is the holy grail to AI is snake oil, take your pick, and everything in between as a spectrum. And I think a perspective to think about how we're going to do this is to think in terms of a comparison to what we do now using natural intelligence or human intelligence and the differences that come in. So, for example, when we talk of AI and human intelligence, it's neurons which spark creativity. They make these paradigm shifts in thought, while AI unravels complexity in layers, if you want to think of it that way. Similarly, human emotion plays a lot of a big role in decision-making for humans, while with AI, it's more a precision tasks. Humans learn by trial and error. It's an iterative process. AI uses backpropagation most of the times. And the experience of trial and error, backpropagation, is different in different contexts. We all learn. We have different levels of wisdom. The AI memory systems, as yet, are all in the future as such. And the contextual wisdom which humans have, which AI doesn't at the moment, and AI is essentially a task-specific skill set that we're looking at. So really, it's the awareness of these differences and these perspectives which will essentially help us in deciding how we're going to deliver this responsibility in all its particular aspects efficiently, and which would allow AI to deliver its potential at the same time as establishing a framework for using it safely and effectively for the benefit of humankind, whether it's in the north or the south or the east or the west. Thank you.
Thank you, Milind, for making such an excellent points around stakeholders, regulation, and also diversity of perspectives. Hopefully we'll be able to revisit this when we discuss further. Next, I will try to bring you, Will. I have your slides, so I'm going to play them, if that's okay.
Yeah, that's fine, and I'm sorry I can't do it myself. This is my first time on Zoom, and there's some security issues.
No worries.
So, yeah, as I say, these are a little bit erratic and not as well articulated as the previous, I guess. The other thing to say is that I'm from Yorkshire, and we've got in England, and we've got a reputation for being quite straightforward and practical. So, okay, so here we go. So the first thing I'll mention is this book, which was published in 2019, which I think really is a seminal book in AI and healthcare. So it's a book recommendation, really, that everyone that's interested in AI and healthcare should read. It was written by Eric Topol, who's a clinician, but also an AI specialist in the US, and really the godfather of AI and healthcare, in my opinion. And I think this framework, when you're talking about something that might transcend the North and the South, or Western cultures and Eastern cultures, this framework might be one that does that to some extent. So he argues that what we have currently is shallow medicine, whereby, and this isn't the clinician's fault, by the way, before I say what shallow medicine is, whereby clinicians are working mostly with limited data, limited resources, they're stretched thin, and all of these problematic components we've experienced of the healthcare system, partly due to an increasing population and an increasingly aging population and a reduction in staff and funding for healthcare systems. So that's shallow medicine. And he proposes this deep medicine framework as an alternative to that. And he has these three pillars: deep phenotyping, deep learning, and deep empathy and connection. You'll know the middle one. And he says that we should look through this framework when developing AI tech in the healthcare space. Would you go on the next slide, please, Dhaval? and I'll just briefly talk about the 3 pillars. So deep phenotyping is a set of that's it. Is a set of observable characteristics about in our case a patient, for example. And what we work with at the moment is limited data. So in England and the NHS, we have different systems, and sometimes clinicians will not get the full history of a patient. They won't have access to certain medical records, and multiple systems being used. And the deep phenotyping proposal is that we should be looking for more comprehensive data on a person from womb to tomb, he says, so from the day you're born all the way to the day you die. So it should be long data, and it should also be deep data. So not just recent blood test results, but also all of these things in that image there. So we've got the microbiome, so your gut flora and things happening there, your genome, proteome for your proteins, imaging, which you'll know about, but also biosensors like wearables and social graphs, so the people you're interacting with, if you remember in the pandemic. So we want to get all of this information on a patient across the full lifespan of a patient. And that's going to be an abundance of data. How are we going to deal with that? Well, he says we should apply AI to it. He says deep learning, but it doesn't have to be just deep learning. Obviously, there's many other important components of AI besides deep learning. And the whole point of this, he says, is that what's been diminished in healthcare is the patient doctor relationship, because clinicians are so rushed now. They get very little time with patients. They're locked in onto the keyboards very often. So when we're developing these health tech solutions, we should be thinking about rebuilding that patient-doctor relationship. And that's the framework he thinks about. And that's Patch Adams, which is a film from the 90s, which is highly dramatized, where Robin Williams is learning to become a medical doctor, but he also entertains them as well. So he does juggling for the kids and all these things. So he treats the body and the mind. So we want to develop tech that frees clinicians away from the keyboard, liberates them from the keyboard, and gives them more time to spend with patients. So I think that's a good framework, and everyone should read that book. Am I going over, Dhaval, or can I keep talking?
That's fine. Keep talking.
Next slide then, please. So this is, if you want to develop a machine learning medical diagnostic for the NHS, this is the pathway you need to follow. This is my conceptualization of it anyway. And I guess relevant for this particular conversation is that first box, the clinical need and care pathway analysis. So it come up a lot that we need to engage with stakeholders. And I think you need to do that at the beginning, and it needs to be comprehensive, because these are the people that are going to be using your technology. And you have to develop it in such a way that meets the needs and meets the user requirements. And I don't think there's much else more to say on that. I can come back to this if you want, but it's very important that you engage with the stakeholders that are going to use the tech. Otherwise, it won't get adopted. It won't get used. You've spent 10 years of your life developing something. Okay, so this is my research. I don't know if that's relevant right now, Dhaval. These are the things I'm working on at the moment.
Yeah, maybe a bit of self-promotion will not be bad.
Do
you want to talk about at least the new center which you are part of?
I'll be brief on all of these. So I've got an EPSRC grant, which is an important grant here in the UK. So if you're trying to develop a new medical diagnostic, including AI medical diagnostic, it can take you, I hope you sat down now, it can take you up to 15 years from conception to adoption. Why? Because you have to, in the medical space, you have to be very careful. It has to perform well, and the way that you do this is by clinical trials, which are run in sequence. And these might take 3 years each, and then you have to get money for them. And then in the NHS, you have to do health economics as well. So there's all these things you need to do, and you need to get regulatory approval. So it can take up to 15 years, which is not viable for a small business. So that EPSRC is about designing clinical trials using Bayes' theorem to try and condense that 15 years, we hope, to 5 years. So that's that work. And then we've recently, as recent as 5 or 6 days ago, were awarded £13 million by the National Institute of Health Research, which is the research arm of the NHS. The University of Hull gets £11 million of that, and this is for a new centre in addiction and mental health. You might know the culture in England as drinking culture, and unfortunately for some people this becomes an addiction, and there's a cognitive impairment and mental health issues with it also. So we've got this new centre for our region that's going to be trying to tackle these problems, and there's going to be a cross-cutting AI theme, which I'll be leading on, developing predictive tools and maybe systematic reviews that are live documents using AI, and a whole bunch of things. And then maybe, okay, so I'm building a sort of ECG wearable lab at the moment. I'm obsessed with simple devices that have been around for ages that can be repurposed for more complicated things. So ECG and retinal scans, hidden within that data is signals for things other than the things they're usually used for. So from ECG now you can predict someone's age, the gender, kidney function, and things way beyond heart function, which is miraculous. And it's AI that's pulling this out, and it's the same for retinal scans. I'm interested in covariate shift, which I think Koorosh works on as well. And I think hospitals should be developing their own machine learning diagnostics. So I want to figure out how I can make that happen. And I'll stop there, Dhaval. Oh, there was one other thing. I was going to say, you asked about who's responsible, and we talked about this. So it depends. So who's responsible for the performance of the machine learning algorithm? Well, it depends. So if something goes wrong with the algorithm or the software, then the developer's responsible. If the clinician interprets the result incorrectly, then the clinician's responsible. If the patient is using an AI and they don't follow the instructions, the patient's responsible. So as with many questions in healthcare, the answer is it depends. So now I will stop.
That's great. Thank you. So I think a lot of great points, Will, you made. I think that stakeholder, what Milind mentioned and previously mentioned, I think that's a theme running through all the perspectives which are coming here. Also, I think it is great to see that the book you mentioned is written by a cardiologist. Right. So that's, that stakeholder perspective in terms of responsible AI framework is extremely important. And often it is driven by people like us or some of us who are more technology driven than stakeholder or problem driven. So that's great to hear. And hopefully we can unpack some of this later on. So I wanted to bring in next is Professor Srinivasan. If you want to take a few minutes to address this question, but also by all means, please introduce yourself as well.
Sure. Thank you, Dhaval, and others. I hope you can hear me. I was testing my audio earlier.
Yeah, it's all fine.
Okay, great. So I think, one of the advantages of going later on is many of the points thinking of making have already been made very nicely. But one thing, especially for the students in the room thinking about these kinds of problems, but also for the technologists, is that this problem is not just a technology problem, but it's a socio-technology problem, as many of the examples that folks have brought to bear have brought up. Now, if you think about, someone mentioned data ethics, and the philosophy of data ethics, it goes back centuries, and much of the scholarship in data ethics has sought to either define the ethical principles to which an individual or an organization should aspire or adhere to, but also the laws and regulations needed to push organizations towards these ethical goals. And legal frameworks often lag behind, is what we've seen over the course of centuries of human innovation. Now, while these two lines of inquiry are important, particularly in medicine, particularly in healthcare, the third dimension is super, super important, which is that, we have to think about this sort of as sociologists think about as sort of a grounded theory approach, or philosophers, even managers think about a grounded theory approach where, you start to think about what are some of the things that can go wrong, or the threats that their use of advanced analytics and AI can generate, and how do we fix or adhere to them? And I think Will just talked about a few examples in some of the research that he was talking about, particularly for mental health care, which I'm also kind of interested in. Now, we did a study talking about some work that I've done together with philosopher, sociologists, legal expert, where we basically tried to understand why companies, in particular across the world, we focused on, Fortune 500 companies. We're starting to adopt ethical and data AI ethics policies inculcated within their organizations. And some of the questions, or some of the reasons why they were doing this that we found from the study was that, they were trying to look at this from the perspective of corporate and industry reputation. Someone brought up trust earlier, especially in the wake of scandals and things like that. We've seen this play out with major companies and also smaller companies. But also in light of emerging or looming regulation within the EU, certainly there's been a huge push also in the US and India as well, and demand from employees and strategic interest in improving decision-making. So this is key. They really want to, I think at the end of the day, the core, reason why people look at responsible data science and AI is basically improving their decision-making processes and to gain sort of competitive advantages. Many of these ideas hold in the healthcare domain as well. As sort of as someone who's more on the technology front, a lot of my work has looked at, fair and responsible AI. And I think Milind touched upon this. There are different strategies for inculcating sort of fair, responsible, safe AI. It could be as a pre-processing step. It could be in situ, as we call it in the machine learning community. It could be as a post-processing approach. And we're interested in a wide range of those. And definitely, those are the kinds of things that could really make a difference in healthcare. An area that's relatively new, not as much research. So again, for students, if you're looking for new areas, one of the things to think about is what's going to be hot, not right now, but 5-10 years from now. Not much has been done in the space of AI auditing, both from the black box sort of sensing-based approach where you're treating, if you look at a lot of AI auditing strategies that people have been proposing, in the last couple of years and things like that. When you test an AI model, you have the standard sort of train, validate, test. In some cases, you might calibrate for things like conformal prediction. But then AI auditing will allow you to actually evaluate if after you've tested and put this out to market, whether your criterion functions that you laid out during test time before deployment are still valid when you hit the market. And so I like to align this or think about this, the context of phase 1, phase 2, phase 3, and phase 4 clinical trials, sort of akin to something like that. This is akin to a phase 4 auditing process. And there's lots of similarities of ideas that are coming to fruition within the responsible AI space that sort of align with how people do this in the financial regulation space, in the drug regulation space, and so on and so forth. The FDA, for example, in the US. I'm also interested and spend a lot of time thinking about explainable and safe AI in healthcare and crisis response. Just gave a talk at IIT Madras on some of our work in the crisis response space. So I'm not going to repeat that here, but we spend a lot of time thinking about vision sciences. So some of the things Milind was talking about, right up the alley of some of the things we're looking at, particularly in the adaptive optics space. We spend some time thinking about, novel drug discovery and evaluation. And again, as I think Will pointed out, we can discover new drugs, but for that drug to sort of hit market, there's an entire process through which it has to go through. Sometimes it's fast forwarded, but usually it takes anywhere from 10 to 15 years. So it's it certainly does take time. One of the things, across all these different spaces that we work on is that the core idea is to take this, wide swath of information space and organize it into credible, actionable, explainable threads of information from complex multimodal data. So if I take a one-line summary of that, that's what we're trying to do in terms of helping the clinician And this including the countering of misinformation, especially in the crisis response space or public health response space. So back to the sort of one of the elements of your question, Dhaval, as others have pointed out, the who, both who is responsible and who are we responsible towards. It depends. I mean, certainly companies and organizations, the first piece of work I talked about, and then almost all the sort of healthcare examples that we've worked on, it focuses on the impacted population, the patients in some cases, but also the clinician, the person who's sort of coming up with a diagnosis, or in the case of public health, the individual who's responsible for citizens on the ground. And so, I think Will said it best. It depends. It certainly depends on the context. It depends on, what the focus is, and it's certainly not a one-size-fits-all policy. So I'll stop there.
All right, thank you, Srinivasan.
Would it be okay just to add one point to that?
Yes, that's fine. Go for it.
Yeah, I really loved all of that actually. But the one thing I wanted to pick up on is this is the type of monitoring of the deployed systems which you alluded to there, which for my money is the thing that's one of the biggest problems in AI and healthcare at the moment, and the one that's not getting addressed, seemingly not getting addressed. And the thing I was going to say is a response to Raghu this morning when you said you don't see much change in healthcare systems, and that's true. You don't, at the macro level, you don't see much unless something like COVID comes along. But at the micro level, there's changes all the time. So they might get a new scanner, there might be a change of staff, there might be an upgrade in clinical guidelines that slightly adjusts clinical practice. And because people aren't monitoring very well these machine learning models, that change in clinical practice, even a micro one, could result in a degeneration of performance. So I guess, and I think Koorosh works in this area as well, but I guess the reason I wanted to mention it now is because if you're thinking that students are thinking about what areas to work in, monitoring deployed machine learning models is really important in healthcare, and it's something that I'm not seeing systematically happen.
Okay, that's great. And that's a really good segue because Koorosh works in this area. So last but not least, can I bring in Koorosh for your 3-minute talk? Raghu, because you had the keynote, but I'll give you a chance as well if you want to add to this as well. Koorosh.
Thank you, Dhaval. Let me just share my screen. So could you please let me know if you can see my screen?
Yeah, we can see.
Okay, great. So just brief introduction of myself. I'm a assistant professor at University of Hull, or lecturer at University of Hull, working in computer science, and I'm a member of, let's say, Responsible AI group, working with Dhaval research group actually. So as Bill mentioned, I'm working in the kind of, let's say, safety monitoring or model monitoring machine learning algorithm. We developed different approaches like SafeML that was, let's say, referenced by German industry for automotive industry actually. And then we came up with the idea of how we can, let's say, do the monitoring of large language model and SafeLLM. But the topic that I wanted to focus here is the idea of, let's say, inconsistency that we have. So consider some factors of responsible AI. Coming back to the topic that Kevin was mentioning, that what are the kind of, let's say, subjects of responsible AI, or what should we have to kind of consider some system responsible? So there are some kind of, let's say, regulations like EU AI Act that they are defining that, okay, we call a system responsible if they have, let's say, 7 specific criteria, let's say fairness, explainability, and so on. And based on that, they are building that kind of, let's say, regulation. But there are lots of inconsistency among those. Focusing on fairness and saying that, okay, if we are only focusing on fairness and if we want to do the evaluation, what is the sensitive attribution, or what is the sensitive feature that we have? And we had this a study between different standards that we have. For example, UK Act in 2010, AAAS, another standard, FHA or ECOA, different standards that they are referring to what should be fair. And if you check the kind of, let's say, differences that we have, for example, UK Act, we consider pregnancy as a sensitive features. But in the other standards, we don't consider these kind of, let's say, feature as a sensitive one. And then they are not subject to fairness evaluation. So these consistency will be even more when we consider westward and let's say Eastern countries or underdeveloped countries. The cultural, let's say, differences can make it even, let's say, more inconsistent. And the actual idea that we don't have the same rules or regulations over the different countries is that because of the culture or the different, let's say, systems that we have in each country, we might need a different one. But how we could, let's say, minimize the inconsistency is a open question in my view. Again, the other, let's say, perspective that I wanted to discuss is about the one that Milind has mentioned. We call it 5W, let's say, questions or key questions. What, who, where, which, and when. So, for example, again, if we focus on fairness, we could say what fairness metrics are applied and what are the biases that can be addressed, who is impacted by that bias, or who are the, let's say, stakeholder involved in fairness evaluation. Question of where in the process or in the development of a process does the bias originate and how it is mitigated, which sensitive attributes are considered and represented, and when is the fairness, let's say, assessed and during or after some development. And we have this kind of fact that we have different key stakeholders. I remember that Google had this kind of, let's say, question in previous session that, okay, do we have that, let's say, different stakeholders and can we, let's say, make a weighted, let's say, aggregation of those, let's say, results. But the fact that I want to, let's say, imply here is that sometimes the kind of, let's say, perspective or the artifacts that we have for different stakeholders are not the same. For example, if we are focusing on the data scientist part, we are considering some numerical values, checking codes, let's say, checking gradients, numbers, bar charts. But when you talk about regulators, you cannot show the gradient to a kind of, let's say, judge saying that, okay, here is my model and it is explainable or it is fair. The perspective that you have, the different language that you have for the kind of, let's say, regulator is kind of, let's say, another domain. So again, for business owner, for consumer, and for, let's say, advocacy group, you might have a different, let's say, perspective or different domain. And sometimes they are not in the same plate to treat, let's say, equally. So you could not easily, let's say, average the kind of, let's say, outcome of different, let's say, venues or different stakeholders, because the idea that the regulator has is not the same as the idea of the kind of, let's say, data scientist has. And a system, a kind of, let's say, transformation is needed to have them all in one place. And the other thing that I would like to mention is that sometimes because of the society and the layers in the society or the cultural differences, we have different layers and the stakeholders can change based on that. For example, we have, let's say, Financial Conduct Authority in the UK to kind of, let's say, consider as a regulatory for this kind of development of AI. But sometimes in different cultures or in different countries, we don't have that layer. So it straightly goes to the governmental, let's say, level. So based on that kind of, let's say, architecture of the society, we might have different stakeholder and different layers for them. So these are the things that we could, let's say, discuss around and, let's say, have a better understanding that how these systems can be, let's say, more consistent. Thank you, Dhaval.
All right, thank you so much. So we have about 20 minutes for questions. I would start off, but audience, please feel free to ask questions in the chat. I'll keep an eye on that. And before I ask my question, which is going to be around the collaboration between Global South and Global North, I'm quite conscious that even the panel is imbalanced to Global North. Raghu, you are the only one. But I think we have all of us, rest of us, have a broader outlook to to the work we do. Some of us are born in Global South, so hopefully we can still have a great discussion on this. And Gokul, I know you're not part of the panel officially, but if there is, I will not direct any question to you, but there is anything you want to highlight, just let me know. So you're informally part of the panel. The other thing is we don't have to raise the hand in the Zoom. Just point out, because I can see everyone, and I'll try to bring you in. So the first question I have, and I'll try to, because I had written it down, I'm going to try to put it here as well in the chat, is why should responsible AI researchers in global North nations should work with global South? A nice and hopefully easy questions to start with. And I think I'm also looking at the vice versa as well, why global South should look at what's happening in global North as well. Is this sufficiently happening? And what more could be done to encourage such collaboration? And this is very much right into the ethos of this workshop, where we want to start, that debate that responsible AI framework should be more international. Okay. So I'm not picking anybody, but anybody would like to go first?
So may I start as a beginner?
Yeah, sure.
So one thing that we want is the market. Consider you are developing a solution, an AI solution, and you want to dominate the network or the kind of, let's say, the market. Consider you have autonomous vehicle developed in the UK or US, and you want to, let's say, sell it in the, let's say, India or any kind of, let's say, South, let's say, global South, let's say. So what you want to do is to, let's say, see how that technology can be adjusted to the kind of, let's say, this domain. And considering the autonomous vehicle, I could, let's say, bring this example that if you are designing autonomous vehicle, it is not easily, let's say, adjustable to, let's say, culture that we have here. And also kind of, let's say, referring to the presentation that I had, is that, let's say, the inconsistency that we have between these regulations may be a kind of, let's say, existing barrier for any kind of, let's say, technology. So the kind of, let's say, opportunity is the market, but there's an inconsistency and the cultural difference, in my view.
Yeah, thank you, Koorosh. And I think the question also asks what we can do, more in terms of the researchers, but also are there any other roles, other institutional or organizational roles apart from just leaving it to market as well? Yeah, Milind, you want to go next? Yeah, Milind, and then we'll.
I've always seen any exchange of ideas between any two people as beneficial to both of them. And that's exactly the way we should do this. There's an old Sanskrit saying which says, Vidyadhanam sarvadhanam pradhanam. And one of the reasons it says knowledge is the highest level of wealth anyone can aim for, is the fact that the only way to grow this wealth is to freely share it with everyone. So really an exchange of ideas is always beneficial. And the fact that both the North and the South are grappling with the same issues at the core of it, but has different flavors, different variations to particular answers, and how you solve those and what approaches you take, surely benefits a lot from exchanging ideas and learning from each other's failures and successes. So we are all approaching the same issue. We're all approaching the same issue from different perspectives, from different training sets, from different domains we're looking at. Our issues, possibly the problems, the objectives may be slightly different, but at the core of it all, there is a shared core which works across all geographies and economies. So to me, it's a no-brainer. The more we exchange ideas, the more we learn, especially at this earlier stage where nothing really is established. It's at we're at the embryonic stage of AI development and how we deploy it and things like that. So yes, it's a big yes in every which way. And I think every type of forum, not just researchers, but markets, from people who are developing commercial models, from governmental regulatory agencies, because we're all going to have to learn how we do this.
Thank you.
Yeah,
Thanks. Yeah.
if I can jump in. I think so. I've been speaking from personal experience. For the last 15 years, we've been working with crisis responders across both the global north and the global south. And, you know, the challenges in each of these cases, depending on the type of disaster we're working with, is obviously going to be different. But one of the reasons, as AI researchers, and this is again putting my hat on as a professor, you know, why students should care about this, is, you know, we talk about out of distribution solutions and generalizability of AI models. And I think someone made the point about automated vehicles. I consulted with a couple of companies. I can tell you right off the bat that, you know, the software for Tesla's designed in the US are not going to work in India or Pakistan or Bangladesh. I mean, they will come to a standstill. So, I think you do need sort of the perspectives and the challenges being brought to bear in the different places of the world. Not necessarily global south and global north, but really in each country, the rules and regulations are different. So you have to account for that as well. But the main reason why I think it's really important for us to collaborate across these different, and as I said, a lot of our tools have been looked at and leveraged in both spaces, is that, you know, when you look at things like recovery from major crisis, even within the United States, you know, if you look at recovery, and this I can speak about rather candidly, we've published work on this, you know, the recovery process for, you know, FEMA is the main organization for response and recovery in the United States, the Federal Emergency Management Unit. And the FEMA has an algorithmic decision-making process through which it determines how much to sort of give back to the communities that have been impacted. And while on the paper, you know, the idea, the algorithm, or whatever they've used over the past few years seems reasonable. If you look at recovery rates, actual recovery from a disaster, the disadvantaged are actually further disadvantaged. There's a broadening of this sort of disparity between the rich and the poor, so to speak. And so it's really, really important to think about these things carefully, not just, you know, in the context of the particular problem you're looking at, whether it's crisis response or vision care and things like that, but also in the space of, you know, how can this help my algorithm generalize? So there's a real and pressing need for this in terms of fairness, in terms of, you know, diversity and supporting, you know, disadvantaged individuals, but also, you know, from an AI standpoint, if you really want something to generalize out of distribution, it's really important to have this collaboration, and we can learn from each other.
All right. Thanks, Srinivasan. I'll come to Will, and Will, you had your hand up.
No, I think it's a no-brainer. We should be working together. Why? Well, disease don't really care if you're in India or England or wherever. We're dealing with the same diseases, more or less. You know, cancer doesn't much care. It's everywhere. And then paired off with that is that in healthcare there's a sparsity of data. So we're always struggling to get data. So we're working together, at least from a practical perspective, we can collate data. Now, I take the point that the populations might be different, but there's an opportunity for data sharing there. So that's the practical advantage of doing that. The barrier. Okay, so how do we make this happen? I think events like this. So I don't have the connections currently to make it happen. I know the people I know are mostly based in the NHS in England and scientists in England. I didn't know, you know, many beyond that. It's not strong collaboration. So events like this, I think, is the way to make it happen. So I have to congratulate you on connecting people and forming collaborations. I suppose barriers to that is often funding. So getting funding across countries, that's less easy than it is to get it internally within a country. But yeah, I think we should be working together. There's practical advantages to it. We're dealing with the same diseases, and events like this help to make that happen, I think.
All right, thank you, Will. I will try to bring Raghu in, try to be a little bit provocative on the same point, because in your talk, I think you said something which was wonderful, which was, responsible AI aspect in Western world is do no harm, and we need to be much more bolder and raise the bar in terms of AI. And I was just wondering, that is a criticism there in terms of, for a Western world, if you want the more complexity of the same problem, at least in terms of scale and diversity, you look at Global South. And I was wondering if you wanted to expand on there. Specifically, you say that there is a different way of thinking and different way of doing this.
No, so Dhaval, I mean, by the way, the answers to two questions you had earlier for me were quite simple. Who are we responsible to? It's the people we are trying to serve, right? Usually the moral bar is higher than the regulatory bar. That's one. The second thing is, one size doesn't fit all. There's a reason why there is a district court, right? And there's a reason there's high courts in every state, and there's a Supreme Court, right? And not everything can be centralized. There might be underlying principles. In this particular case, there's constitution, law that underpin how these things function. But I think what we are in search of really are distributed systems, right? That said, I will say that the bar is higher than do no harm. Do no harm is when you go to jail, right? That's when you are penalized. That's a pretty low bar for us to run as a society, isn't it? Like, great day, I didn't kill my neighbor, right? I mean, like that's kind of so I'm hoping we can hold ourselves. And I do think that there's a lot of the benefit of collaborations anywhere, doesn't matter what the borders are, is to learn and to be sensitive, right? I generally have the fear that right now the dialogue and the media, social media, there are a few loudspeakers, and these are so much of content is generated by people with certain backgrounds that those are the messages that reverberate. And so I do think there are contexts, because what do you mean by do no harm when I do not even have a doctor, right? Well, the bar on AI here is to bring the doctor, or bring a doctor like, or despite not having a doctor, can we provide adequate care, right? So just the level of responsibility suddenly is, and what the responsibility is very different. And I think that can be learned only this thing. The other thing is, I would say that, in fact, places like India and many other countries in Africa provide an opportunity to look at these things afresh, right? So I actually want to kind of be very careful about the traditional, even in academic circles, what's been this sense of generally borrowing what happens in certain economies and applying it as is, right? We do that with medical device regulations, for example, but like I said, the contexts are not well represented for black box AI, and hence it would be different, right? How does still allow for human oversight and final decision making? I'll just respond to that very briefly. I think for me, the answers to everything comes down to how we build AI. I'm actually not a very big fan of responsible AI. I say that's like saying responsible knife, right? Because, like, what does that mean? The knife Like, does it go commit murder or does it cut vegetables? Does the knife have a handle? Whatever these things, right? So I think a lot of it comes down to the how of how we build these AI-based solutions, as well as how we then monitor, continuously improve. And so that's why a lot of my work has kind of drifted from being very innovation oriented or one particular solution oriented to more and more about the systems we build. Yeah, thanks for the opportunity, Dhaval.
Thank you, Raghu. A lot of great points. Milind, you wanted to come in quickly. Yeah.
I just wanted to invite Raghu to perhaps. So in classical medicine, when we say do no harm, what we really mean is that whatever you do, whatever treatment you apply, should not make the patient worse than what they are to begin with.
Yeah.
That's not how you describe do no harm. What you're describing is that there is a lack of opportunity to provide healthcare, or they don't have access to it. And rather than getting lost in the minutiae of how we do this and things like that, it's much more appropriate to find a solution to that immediate thing of getting people access to good healthcare. But that's slightly different. It varies. So really what I'm saying is whatever AI solutions, whatever solutions we design, if as a result of the solutions, people are worse off.
Yeah, I agree with you. There's absolutely no. All I'm saying is for me, what I found is the do no harm principle often leads to inaction, and that's not acceptable, right?
So it's like playing defensive cricket. It's a loss of fear, loss of losing that stops you from going on the aggression.
You never win, right? So there's
Correct.
no chance of winning, right? So
yes. You have to risk.
So, and to me, that's a kind of harm, right?
Okay.
So that's basically it. So
That's great. I don't want to stop the discussions, but there are one or two areas I really want to cover. So the second question is, and I've tried to paste it here, and possibly there was a relevant question Chitralekha asked as well. Both questions are related, so you could read both and try to sort of, weave your answer to address to both or one of them. But my question was, how does responsible AI researchers or frameworks can address patient autonomy and the right to understand and challenge AI decisions? So we talked about stakeholders quite a lot. Patient is the stakeholder in this. So how do we do this? Thanks.
I can address the first one very briefly. It's in the fundamental design of the solution, right? So whenever you build a solution, it's not just the model, it's a bunch of actions before, bunch of actions after, and how do those happen. So having human oversight at the appropriate place is eminently doable based on the type of solution you're trying to build, but you have to be deliberate about it, not incidental. Ask where it's really required.
Thank you.
I would, if I could come in, Dhaval, I would actually, there are many contexts in which that particular framework just won't work. So what we're talking about here is an AI which interacts and directs output to the patient without any healthcare professional intervening in between. Okay, that's quite a task. That's quite an ask for any AI. In fact, when we sit and talk to patients as doctors, it's very evident that it doesn't matter how much you say to them, they're barely taking about 10-20% of what is said to them. So how we communicate, and that requires repetition, that requires different formats, that requires maybe presenting the data in digital formats, which is user-friendly, which is understandable, relatable to the target population, and perhaps get healthcare professionals to translate that across, not translate, what I mean by translate is to communicate that across, along with the digital systems, to get the message across, because it's very important for patients to understand what's wrong with them and what the treatment's going to do, and the expectations from what the treatment is able to do and not able to do. So at this time, I mean, one can very easily imagine a chatbot trying to do this, but believe me, when I sit and talk to patients, it's quite a challenge even for trained professionals to start answering those questions that come sometimes.
That's great. Thank you. I think if I had to twist that question a little bit, where it's not AI making the decisions are explained and made by, at the end, by the clinician and doctors. However, whether it's a regulation or frameworks which requires the clinician to make it clear that there is an involvement of AI into this decision-making process. So if we take that angle as well. So Will, you wanted to come in?
Yeah, I just wanted to say, I think there's some great points there. And I think the key responsibility we have as scientists, and I'm a scientist, and clinicians, is that the patients understand. So if you've got an AI technology, they understand as best they can what it can and can't do. So it's 90% sensitive, 91% specific, what this means, the uncertainty about the result. And funnily enough, Milind, when you said about patients not taking things in, when I go to see a doctor, I think my blood pressure goes high, and I get the white coat syndrome, and I remember about 5% of what the doctor says to me. So I've experienced that as a patient. But I think just a responsibility that the patient understands the limitations and the extent that the technology, the medical test, can offer. And it's not just AI, this is all medical tests, I think.
So you can start thinking of having one consultation lasting an hour.
If I can jump in real quick. So I think the point that to Chitralekha's question, I think it has to be sort of human directed or human in the loop, depending on perspective. So in this case, the clinician would ultimately have some kind of control over the interaction with the patient, even if it's through a chatbot. And I think Amit's going to talk about that anyway in the next talk. I see he's just joined us. The other sort of question, Dhaval, to your point, and this is something that Will brought up earlier, which I think is super, super important, is that, and it's related to what Milind just said, it's about how it's presented to the user, and presented to the user in a way that the user can understand, whether the user is the patient, the clinician, or someone in between. It needs to be presented sort of in an empathetic manner, especially, for example, I think if you're looking at working with mental health patients, needs to be presented very, very carefully. I mean, with all kinds of patients, but a particular note of interest, some collaborations I have, when you're dealing with mental health, folks who suffer from various types of mental health problems, you have to be extremely careful in how the chatbot presents itself. Otherwise, it can go, especially with today's LLM technology, it can go completely awry. The other thing that I think, and no one's really brought this up, but this is kind of important in this context, is consistency in decision making and sort of, a consistency in the responses you get from the chatbot, because we've seen that current LLM technology is really not very consistent in with small perturbations. You can see wildly different responses. And so that's a challenge for the AI researchers to sort of, deal with, but also a challenge for clinicians and patients to be aware of when they interact with such systems, at least such systems as they are set out today.
Perfect. Thank you so much. I still want to get in one question, if that's okay with you, Amit. Welcome, Amit. Professor Amit Seth, I think, have joined. I will make sure that you still get 40 minutes for your talk. We still get 5 minutes for question after your talk, and we'll still finish at 7 o'clock because we are not doing this in person. So we should be able to still manage that. So I will still try to get in one question. which is what I pasted. This is around education. I think this is very important. We should try to cover this, considering the bench strength we have in the panel. So the question for academics on the panel is, when designing courses in AI for healthcare, which some of you have designed and some of you have designed recently, what key elements should be included to make sure that the training is globally relevant? Do we need to do that? And if we do, how do we make that it's globally relevant? And the second part of this question, and I definitely want to come to Kevin, to you to start with for this one, but the second part of the question is also directed to practitioners on the panel. Clinicians will be working more and more with AI, might be asked to even train AI systems. What are your expectations from educational institutes around this issue? So we can start off with Kevin.
Certainly, thanks for the hook there, Dhaval. I can probably just answer that with one word, which is to say ethics, because I think if you don't train students for ethics and you don't train them to think critically about what it is they're doing and implementing, and if you let them rip without putting a human in the loop, I think you're going to set yourself up for a lot of problems, because the blind trust that you might have in algorithmic responses is not always correct. And I think this goes back to your original question, Dhaval, where you asked what's the benefit of the collaboration between North and South, because the reality is, by the end of this decade, all high quality sources will have been harvested for AI training. And you can think there of LLMs and, say, books or, journal articles and so on. And then what are you going to do? Are you going to go to blogs? Are you going to feed off your own tail? Or are you going to do something sensible by getting more data from everywhere in the world, so that the applicability actually grows and your confidence in the answer will also grow? However, I think having that human in the loop and having students trained in ethics, which for our course at the University of Hull is woven in almost every module that they do, and indeed you have to undertake an ethics clearance before you even do a project, which I assume is very common throughout the world. There really is a question there as well, not only about ethics, but can your patient even comprehend what the recommendation is? And this crops up very regularly because, of course, most people who are being treated, the vast majority are laymen, and they do not understand the terms, and they do not understand what treatment sometimes means. And can people actually consent under those circumstances? I realize I've probably raised a lot more questions than I've answered there, Dhaval, but I wonder if colleagues want to come in there, and I'll just leave it there politely.
Yeah, thank you. If I bring in Professor Srinivasan at this point, sorry if I missed your raised hand before, but if you wanted to, I don't know whether you wanted to come in.
Sure.
On this.
I think so. Speaking from the experience of creating a program 14 years ago, it was a program focused on data science, one of the first undergraduate programs in the US, maybe even international. One of the dangers with, so one thing I will say in regards to your question, Dhaval, is, we can't possibly include everything under the sun in a course or even in a program of study. So you have to figure out which are the key or important elements that you want to make sure that everyone takes away. So I like to think about even courses in sort of a hub and spokes model, where there are sort of core elements that you cover in the first part of the course, and then you allow students the opportunity to specialize into specific silos. So even within healthcare, even within image processing, for example, even within ophthalmology or vision sciences, the kinds of image processing that you need, for example, to treat keratoconus versus understanding diabetic retinopathy or understanding glaucoma, it can be quite distinct. The kinds of image processing technology depend on the product, the whatever sort of source, whether you're using adaptive optics or whether you're using a keratoconus device of some sort, a video keratograph device. And so whatever, in each of these cases, the image processing is going to be slightly more nuanced, slightly distinct. And so the key is to give students sort of the core idea of some of the common image processing techniques, and then allow them to sort of specialize either through course projects, or if it's a program you're developing, through specialized courses that allow them to specialize in whatever domain, in this case, the clinicians or doctors or students are trying to focus on. And that's really, really important in the health sciences, because the kind of image processing techniques you're going to need in the vision sciences are going to be different from what you need in radiology, are going to be different from what you need in other areas. So, and you can't possibly include all of it. So the one sort of caution I will have is there is a tendency to be all inclusive, and that's just not going to work. And so you have to really think about this very, very carefully.
Thank
prioritize.
you. Really well made points. Will, if I can bring you in, but request you to do it in 30 seconds, if that's okay.
That's fine. That's fine. I'll be brief. It's a bit of a shameless plug, really. So the University of Hull and DAIM are launching a master's in AI for healthcare in January, and I've been involved designing that. And the key thing I would say is, you've got to teach the technical skills. You've got to learn how to model and program, but you also need the translational, that's what we would call it, translational skills. So understanding that you have about the stakeholder engagement, about how you do reviews, systematic reviews, qualitative research. Otherwise, you're developing tools that no one needs, no one wants, and it's going nowhere.
So just a quick one. One of the techniques that a friend of mine in Moorfields uses, who leads the digital innovation thing, is she runs hack days, NHS hack days. So over a weekend, clinicians, AI, technical people, coders, everything, they just come together and run this exercise of identifying smaller problems, going through the methodology of how to try and solve that, what are the techniques we need to use, and that problem solution, that AI solution that Raghu was emphasizing all the way through, that collaborative approach, then becomes embedded with that kind of thinking. And I think
Perfect. Thank you. Thank you for your input, Milind. I think I'm really sorry to say that I wanted the discussions to go on, but we'll have to stop now. Thank you, everyone, for your contribution. I think I at some point, you didn't see that, but I messaged Gokul that, are you sure we are recording this? Because this is a gold mine. So all your contributions has been